Hello, everyone. Hello. Welcome to this webinar dedicated to the practical session on shockwave therapy with the Swiss double-class method. We are happy to welcome today Tina Maio from Australia, our shockwave expert of the day. Hello, Tina. Good evening, Tina.
Hello, everyone.
So we are honored to have you for this practical session and very excited to see what will be going on today. Before starting this webinar, I would like to quickly introduce myself before giving you the stage, Tina. So my name is Marie-Christine Collet. I'm responsible for educational activities promoting the Swiss double-class method within the company EMS Electromedical Systems based in Switzerland. So EMS Electromedical Systems developed the Swiss double-class method in the early 2000s. We are happy to promote with the Swiss double-class Academy and offer shockwave training programs to healthcare professionals to become the shockwave experts of tomorrow. So that was the introduction for my side. Just to precise a few technical points to our participants, as you can see on your screen at the bottom or the top of your screen, depending on your configuration, you have a Q&A icon and a chat icon as well. You can use them to ask your questions, mention some comments. Please do not hesitate to ask your questions. We'll be able to answer them during the course of the webinar. So that was for the introduction. So thank you all for joining us online today. So we will be talking about practical hands-on application with shockwave therapy. Tina, the stage is yours, so you can start now.
Thank you, MC, and thank you to the Swiss double-class Academy for inviting me back to speak again. It was great last month. We had a great presentation, and hopefully some of those people who participated last time are back tonight to listen, or this morning over there. So, I'll get started. So yeah, today we're going to go through just a few slides because we have got some participants that the Swiss double-class before. And then we're going to get into the practical session. So I'll just give you a quick rundown about what to do. That's not working. Hang on. There we are. Okay, so why do we choose, we're going to go through why we choose radial shockwave therapy as a treatment. How it fits into a treatment model, so for a patient that comes in, the settings on the device, the different types of devices, and the energy curves they give us, the therapeutic effect, and how it basically works to diminish pain for patients. We're going to discuss the three most important things about the shockwave, which are cavitation, substance P, and lubricant. We're going to discuss some research that's really prevalent and very applicable to some of the conditions we're going to discuss tonight. We'll go over contraindications, some patient management, and some protocols for knee osteoarthritis, plantar fascia, body and insertional Achilles tendinopathy, tennis and golfer's elbow, and greater trochanteric pain syndrome. So that's our rundown. So why do we choose therapy? Our patients expect us to be informed. They expect us to know what is the latest technology available, what other options do they have besides surgery, besides injections, besides all these different things. So it's very important that as practitioners, regardless of what modality and what background we have, that we're up to date with other things that are being offered and solutions for their pain. So people are very impatient. We often use shockwave on very chronic pain sort of people. And the pain's affecting their lifestyle. So we need to know the options available for those people that are conservative before we do anything more major. Patients want the same experiences as the elite people. They want to know what are the best people, like what are the best athletes in the world having? I want the same treatment as them. So they expect the same and they want the same, and they will find you if they know that you offer this treatment. So we have patients coming to us purely for Shockwave, and they don't even know anything else that we do, but they know we offer Shockwave, and that's enough for them to come. And they heard of that, they heard it's successful, they've heard it's internationally recognized, we have the best equipment available to offer this treatment. So that's enough for them to want your services. Objective data. So assessment and reassessing patients after you treat them is really important to reinforce what you've done. And Shockwave therapy, it's easy to have a pre and post assessment with this treatment. Patients want immediate changes in feedback and pain. So again, this is a treatment method that does give them an immediate change. So it's very positive in that regard, and it helps build their confidence in you. Speed up recovery and healing time. So every single person I see would like to get better quicker. And obviously anything that's going to improve blood flow, improve oxygen, lots of techniques we use aim to achieve the same thing. So if we've got a tool that can do that a little bit quicker and more effective in a shorter amount of time, we're saving the patient time and money as well. And it may assist with a diagnosis. So quite often patients, you might not know what's going on with them, but you can use this sometimes to actually arrive at a diagnosis in certain conditions, particularly around the shoulder where you've got lots of tendons involved, around the knee where we've got lots of things attaching. So sometimes it is a good tool to try and work out what is the greatest source of the pain. So if we talk about where it fits in the treatment model, so we have patients come in, we take a history, we do an objective assessment, we then reset dysfunction. So we might use lots of different things to do this. So Shockwave is one of those things. So you might do some hands-on treatment as well, some dry needling, some cupping, some muscle energy, some manipulation, all these direct or indirect techniques. Shockwave just fits into that same category of a tool that we use to reset dysfunction in people. Then we reinforce what we've done. So we might use tape, we might use some more needling, we might use a brace or a support or some exercises they have to do when they go home. So we're reinforcing what we've done with the Shockwave to maximize the benefit that with the treatment we've given them. Then we reload them. So we give them more load, more stress to make sure their body builds up a capacity to tolerate more stress. And so that makes sure that they're conditioned and that the pain doesn't actually return. So it's really important that we're thinking big picture and making sure we're helping these people long-term maintain mobility, maintain strength, whatever they may need. And then this allows them to return to sport, activity, and then we might need to give them a plan to assist with recovery. So every time you do this, you have to do this. And then that just becomes part of maintaining whatever injury they may have. So the setting. So on each unit, there's a few different things you can change. So one of those things is pressure. So the pressure that's delivered to the handpiece, you can control how much pressure is delivered. And therefore, the more pressure, the more energy you're putting into the tissue. So we know that, you know, for deeper indications, we want to put more pressure in, and we want to try, and people, as they get better, we want to up the pressure to maximize the most amount of energy. And different devices give us different, allow us to change that as well. So impulses, how many shockwaves you're going to give that area or that tissue. The frequency, how many impulses per second. The applicator size, so we've got a 10, a 15 or a 36 millimeter. So again, depending on the tissue, which one are we going to choose? So really important we have a good understanding of our anatomy, the layers that we're treating, and understanding like how deep we're trying to get the treatment to work. The applicator spring pressure, so the head of the device, which I'll show you later, has a spring in it. So again, this compression of the head is really important. Otherwise, the shockwave doesn't go into the patient, it ricochets back into you as a practitioner. So all those things are really important, that we realize that we can alter all those 5 things on any machine. So if we talk about devices, today I'm going to show you 2 of the devices. One's the Evo Blue handle, which is like the one in the picture that you're looking at here. So we've got little bursts of compressed air that come up through the compressor that's external. It goes into the handpiece and it's controlled by a valve. There's a little projectile that's inside the guide tube, and that accelerates at a really high speed by the bursts of compressed air. So we know that this projectile can hit the inside of that applicator at 90 kilometers an hour. So it's very quick, and the energy gets converted to a shockwave that's transmitted to the tissue, through, obviously into the patient. And we use a gel because we know that shockwaves travel better through a liquid than through just air. We've also got the power handle, which is a red handle, and that is a little bit of a different device. It's much more powerful and used for more bony indications. So the Evo handle we tend to use for tendinopathies a lot and for musculoskeletal type indications. So this graph of the energy curves just compares the power handle is the red triangles at the top there that you can see. So if we have a look, it delivers the shocks, the energy density it delivers is quite high, and then it diminishes and drops off and tapers, and you can see that going across. So overall, it still gives us the most amount of energy, even though it tapers off. So we know if we're treating something like an osteoarthritic knee or an osteoarthritic ankle or a calcified supraspinatus tendon, anything that's bony as such, we know research tells us that this is the device that we should be using. Okay, so those bony indications respond better to a high energy density that happens quickly at the beginning. And even though it tapers off, that's okay. The blue dots that we can see here are the Evo handle, which you can see it very much delivers a more constant energy density over a period of time. So it doesn't really drop off as quickly. We talk about our complex energy signature. So for those of you that maybe heard my previous presentation, I talked about this a fair bit because this is what makes the difference between a shockwave machine that's very effective and a shockwave machine that's not effective. So if we don't have a large, this is our shockwave here. So this is a positive pressure, positive energy density that we can see in the lighter blue. So if we don't have a big shockwave that happens here and a strong shockwave, we don't get this negative effect in the darker blue here. So this is our total energy density that we can see. But the negative pressure here, this is where cavitation occurs. So we're creating a negative tissue pressure, which means you're getting little oxygen bubbles happening in the tissue. Little bubbles burst, and that motion, that oxygen, that blood flow you're creating in tissue creates a rippling effect, and that's actually the therapeutic effect and why shockwave actually works. So if we have a shockwave that's not as strong, it doesn't dip into this negative space, that we're not going to get a therapeutic change. We're basically, it may as well be like a massage device. It's not enough to actually have a therapeutic change. So this is the stress in a tissue. That was the other thing I was going to mention. So really important that when we do compress the head, we want to send as much energy into the person so we get a bigger positive spike here, and therefore we'll get a bigger negative drop here. So we're going to get more negative pressure if we compress the head more and send more energy into the patient. So I've pretty much so the cavitation bubbles have less pressure. So that creates a small jet stream within the tissue is really what changes. And you can feel that if you're palpating tissue, you can actually feel the change in tissue once you've created cavitation. So everything gets a lot softer. If you've got like big trigger points, you feel the tissues feel quite different after you've done the shockwave, and purely because all that tissue gets the blood flowing, it encourages healing. So scar tissue responds really well. And this is where you can really appreciate that therapeutic change in the cavitation that you've created. The removal of substance P. So when we have an injury, obviously we have our C nerve fibers that report pain. Remove that. And they release substance P in the tissue and in the spinal cord. So if we have a look at this picture, you can see if this is our spinal cord, this substance P floating around blood vessels, the mast cells, we've got histamine, we've got damage to the cells, and these are our C fibers that report the pain back. When we have shockwave, and when we apply shockwave, that depletes this substance P, so it gets rid of it. So we can't feel the pain because the message can't get back. So less substance P also reduces inflammation, which is really important because more often than not, that goes with most injuries that we see. And if we got a decline in this neurogenic inflammation, this will obviously foster healing. And it also releases growth factor, and it helps activate stem cells in the treated tissue. So it's pretty powerful that you think although we're removing a substance and that's creating a local analgesic response and numbness, it's really important that we can appreciate how important those are, and if we can actually reduce those, then we're going to have an impact immediately.
Tina,
That's the biggest difference. A lot of other treatments might not have such an immediate effect.
Tina, can I interrupt you a second? Could you please repeat the 5 minutes before when you were talking, because there's been.
Can you hear me?
A small cut. Yeah, we can hear you,
yes,
but there has been a small
sure.
cut during a few minutes. Can you hear me?
Sure. So what part do you need me to go back to? Yep.
Just
can you hear me?
Yeah, I can hear you, but there have been some small cuts. Maybe if you're when you were talking about substance P and just after substance P. Well, I cannot tell you exactly because it was during your talk.
Okay.
Yeah.
So I'll just go over this slide again.
Yes, if you can, that would be perfect. Thanks.
Okay. No, what's happening?
I don't know. Sometimes it's cutting. I don't know. Yeah, we will. Let's start again. Maybe about substance P. Yeah.
Okay. Yeah. I'm just having trouble flicking to my next slide for some reason.
Ah, okay.
Sorry. Oh, there we are. Sorry, we're good.
Perfect.
Okay, so when we have, can you hear me now?
Yes, loud and clear.
Excellent. Okay, good. Let's go again. Okay, so when we have an injury, we have our C nerve fibers that report pain. So this picture, the C nerve fibers are the green fibers there. And they release a substance P in the tissue and the spinal cord. So you can see the substance P is in the mast cells. We've got around the blood vessels, we've got inflammation, we have all these things. So when we have shockwave, it actually deletes the substance P, so we no longer feel the pain and we get a full analgesic response. So this is like, some people talk about this as numbness in the area, but that's what they feel immediately. So when you're palpating, you'll notice a change in how sensitive that is afterwards. So we know that less substance P also will reduce inflammation, and this will in turn foster healing. It will help release growth factor and will help activate stem cells. So it's very powerful in this removal of substance P. So it does more than just remove pain. It actually helps activate stem cells, which not many other things can actually do that. What is happening?
We can still hear you, so that's fine.
You can hear me?
Yeah.
Okay.
Yeah, it's getting better.
Okay, that's good. I don't know why it's doing that. Sorry, I can't flick to my next screen here.
No problem. That's the magic of live sessions.
No, that's not. It worked before. I'll try and take that off. Just leave that. Yeah. I might just reshare the screen. Is that okay?
Yeah, sure, sure.
Yeah.
We'll get back to it.
Here we are. Okay. So can you see that?
So now I don't see your screen. No, I don't see your screen, but if you can share it.
Okay. I will try again.
So now I can see your screen on Lubricine. Yes.
Yes, perfect. Okay.
Perfect.
All right, good.
Good. Perfect. Perfect.
Sorry about that. Joys
No
of technology.
problem.
Okay. So lubricant. So this is the other big benefit from the radial shockwave therapy. So it's a protein.
I cannot hear you
and when
now.
I say
I cannot hear you anymore.
at all. Oh, now it's saying my connection's unstable.
I can hear you, but it's, yeah.
Can you hear me now?
Yes, now I can hear you.
Okay.
Yes. No, I don't know. Sometimes, yeah, could be the internet quality.
Can you hear me now?
Yes, yes, I can hear you now. So let's start again on Lubricine.
Okay. All right. So lubricant is secreted by the chondrocytes of the cartilage and by the sheath that surrounds the tendons. The fluid forms a thin layer at the surface of the cartilage and it seeps into the little cavities and irregularities of the articular cartilage. So if you have a look at this picture, these little grey long bits here are lubricant. And this is our cartilage here that lines the bones. Our synovial fluid sits in the joints. So it is actually really important that within the synovial membrane of all these joints, we've got all these little lubricant cells that attach there. So if we've got more lubricant, we've got better gliding action where the joint surfaces meet. So we've got lubricant and hyaluronic acid, which provide a cushioning effect by storing and dissipating the energy created during an impact. So to help shock absorb all our joints and take pressure off those spaces. Lubricant's created in the thin layer of tissue that lines the joints. So if this liner becomes inflamed, then production breaks down and may even stop completely. So we know that inflammation that's associated with arthritis destroys lubricant. So we know we've got a study to show us that shockwave and joint motion increase the production of lubricant. So if you've got a very dry arthritic joint and you can stimulate the production of lubricant, then all of a sudden this joint's going to glide a lot better. So being very being very good with your anatomy and sometimes having an x-ray of a joint that's quite arthritic is really helpful. So you can see where more of the damage is, or if you've got an MRI, that will give you a bit more information. Then you can areas that are really worn and where there is not much fluid left. So we can have synovial injections into joints, those sorts of things can help. But rather than having to do something more invasive, shockwave is a great first tool to try improve the mobility of an arthritic joint. So and if we're talking about a tendon, when we have a chronically inflamed tendon, very dry, they get very thick, they get very brittle, and they rub on the sheath that surrounds the tendon. So if you can get that tendon sheath to secrete more lubricant, all of a sudden that tendon glides in and out of the sheath much better. So both for tendon problems and for joint problems, this is probably the biggest draw card. And this is almost the best way to, if you explain this to your patients, who wouldn't want their joints? So it's very easy to convince them if you explain to them that this is one of the only ways we can actually stimulate your body to produce. Really?
Ina, I have a quick question. Is lubricant decreasing when you're getting old?
Yes.
Or yes, okay. So it's a degenerative
Unfortunately.
process. Okay,
Yes.
unfortunately. Okay.
Yeah, that's
I cannot hear you now.
um
I cannot hear you anymore. Yes, I can hear you.
you can hear me now?
Yes. And I have already I have a question from a participant asking, can we then motivate to some shockwave treatments in an attempt to delay replacement surgery?
Very much so. Yes, we can.
Mm. Okay. We'll be talking, by
Okay.
the way, during the practical session, because this
Yes.
is a question linked to
It's a practical question.
yes.
Okay. All right. So
All right. So now you're waiting for your screen.
sorry, can you see that?
Not yet. It's yes. It's coming back. It's coming back. I have your screen, but I don't see your slides yet.
It says I'm screen sharing. Can you see them there?
Not yet. I can see your screen.
Try again. Share screen. How about now?
So I have a message saying Tina Maio has started screen sharing. So we are waiting for, I don't know what's happening today, but we have no
But you can't.
We don't see your screen. We cannot see your screen. I don't know why. It's like it's trying to log, okay, now I can see your screen,
Okay.
but I don't see your slides. That's part of the beauty of online training. We are adapting to the online, the internet quality of the day.
Yeah. We didn't have an issue last time, so
Yeah.
now I've just done it again. Can you see my screen now?
So I can see your screen, and yes. Now we can see that you can see your screen with the approved indications. Perfect.
Yes. Okay. All right. So the tendinopathies that are on the list here, so calcifying tendinitis of the shoulder, subacromial pain, long bicipital tenosynovitis, tennis elbow, greater trochanteric pain syndrome, patellar tendinopathy, Achilles tendinopathy, and plantar fasciitis, adhesive capsulitis, trigger points and myofascial pain, chronic muscle pain and acute muscle aches, chronic lumbar and cervical pain, superficial non-unions and stress fractures, and Osgood-Schlatters disease, knee osteoarthritis, stimulation of acupuncture points and trigger points, painful exostosis such as a heel spur or Haglund's deformity, proliferative disorders, delayed union and non-union fractures, and skin diseases such as chronic soft tissue wounds, primary and secondary lymphedema and cellulite. So these there's studies to support all these indications. So we're not going to discuss all of them today, but just so you have a better understanding of just to the amount of things you can actually treat using Shockwave. So if we talk about the efficiency on osteoarthritis, because we have a real patient with a very osteoarthritic knee, so I wanted to show you this study, which was published in 2013. So they had 70 patients with osteoarthritis that were into two groups. So if you have a look at the graph, we've got the blue columns are the ones that receive the Shockwave treatment, the red are the placebo group. The Shockwave group received 400 shocks over 4 weeks at once a week, and the pain reduced. You can see on a visual analog scale. So they looked at pain and disability. So they looked at 1, 4, and 12 weeks. So you can see that even though the treatment only 4 weeks, that even at 12 weeks, there's still a continued benefit from the Shockwave treatment. So you can have a look that here on the week 12, you can see that it's still, the pain's still decreasing. So we know that function, at least, we know that they used a power handle with this study. So that's what I'm going to be using tonight as well. And we know that it's basically showed us it's effective in reducing and improving knee function, at least during 3 months after the beginning of the treatment. So, with patients, and just anecdotally, I can report that, I've seen patients who've benefited for more than 5 years after having Shockwave. So the effects are long-term. It's not just a quick fix. So that's really important. Efficient than injections. So this is another study that talked about the difference between having Shockwave or having a cortisone injection. So in this one here, the that had the Shockwave, they had of Shockwave with 2,000 Shockwaves. Had a single local cortisone injection. So when you have a look, they basically had at 1 month, you can see that both of them improved slightly. So that's quite good. They both had a significant change. And after 2 months, you can see that the Shockwave is better than the cortisone. So the other issue that we have is we know that in long term, we have an issue that it doesn't actually, it's not guaranteed. You probably know someone who's had a cortisone and made absolutely no difference. The other thing is that having a cortisone injection, if you have a very chronic tendon that's already very brittle or not very healthy, and sometimes one injection is enough to cause the tendon to rupture completely. So there's a chance we could do more damage. And the other thing is you can sometimes have a nerve that's secondary to having a cortisone injection. So just in mind that if we're, cortisone can be effective, but so can Shockwave without being too invasive and without risking rupturing the tendon. So the long-term effects, this study here was basically, is there an effective, just saying like sort of long-term what with people, and this study was on a chronic plantar fasciitis. So basically this proved that you can efficiently treat plantar fasciitis and relieve pain on short-term and a long-term basis. So this just reinforces, so this is at 3 months, the Shockwave group again in the blue versus the so this group had 3 sessions and they had in each session. So it wasn't very much to actually help a really chronic. We know that 80% of conditions can improve with 3 sessions. Also, we know that Shockwave is more efficient when it's than plantar fascia stretching. This was a study that was published in 2015. So we know that Shockwave treatment with stretching has a significantly better outcome than stretching alone. So if you have a look, Shockwave and Shockwave with stretching, these are the differences. So again, with the follow-up period of 24 months, you can see at the end here how much better the group that had Shockwave with the stretching. So remembering that Shockwave is a great tool to combine with other treatments. I hardly ever have someone that I only do Shockwave else. So I don't think I've ever done that actually. So it's really important how you can use it in conjunction with other things that you typically do. Okay, it's efficient and it's safe. So I wanted to add this in just to reinforce that for lots of different conditions that we see, this is a systematic review that was done, and these articles are all available on the Pedro base for you to read. But basically, this is just saying that it's a great treatment to help with musculoskeletal conditions. The treatment protocol for most of them appears to be 3 treatment sessions at one with 2,000 impulses per session at the highest energy flux density that can be a patient can tolerate. So it's fine, and we're not damaging tissue. And we'll talk about the contraindications, but overall, it's very efficient and it's very safe using this equipment. The contraindications.
We are losing you a little bit, Tina. This is cutting again. This is cutting again, but I don't know if everyone is experiencing the same. Well, it's getting better. It's getting better. It's like slowing and.
We okay now?
Yeah, we're okay now.
All right, so we don't use it over air-filled tissue such as lung or gut. We don't use it on pre-ruptured tendons. Obviously, if a tendon's completely torn, we're not going to be heard that there's been a problem, but there's nothing to say it won't cause a problem. So it's better just to err on the side of caution. Treat the age of 18, except for Osgood-Schlatter's disease. Things I have used it for severs and those sorts of conditions as well. And some patients under 18 are almost, full adult size anyway. So I think it really depends on where they're at developmentally to make a call on that one. The treatment of patients with blood clotting disorders, patients with anticoagulants, bacterial infection, patients who've had cortisone. If they have had cortisone, it's recommended you wait 4 to 6 weeks after the cortisone before you use Shockwave on the same area. If they've had cortisone somewhere else, it doesn't really matter. But luckily, just be mindful of the fact that they could have an altered sense of what's going on there. The only risks involved, you get pain and discomfort during and after the treatment. We don't use anesthesia with Shockwave because we need the feedback from the patient to tell us what they're experiencing. We might get some reddening of the skin, some paresthesia and swelling and numbness over the treatment area, but they're probably the only we know of. So making sure we take a thorough history from our patient, we must listen really well, assess their function, ask them about nutrition, lifestyle factors. Our patient skills are really important. Make sure we know what our hands are on. Build trust, like we spoke about in the last session we ran. Explain the procedure. Use a pain scale. So ask them if 10 is pain you've had, how is this out of 10? And use that to guide your treatment. Use breathing focus to help the patient relax, reassure this, and we deliver a treatment plan. So we get to understand that this one treatment is not enough and we need to have treatments to make sure we get closer to that 80% improvement. So our protocols, I'm going to show you this on the patient. So it's important that we palpate the area where we're going to Shockwave so we know exactly, and we don't lose our spot. We apply gel, we treat with the Shockwave, and we can relax the muscles around the area if we look ahead sometimes. So I'll show you how I do that. So we're going to now go over these. So the first one we're going to talk about is knee osteoarthritis. So I'm going to introduce you to Mark, who's here, and he's our patient today. Yep, so I'm going to actually see if I can, if I do that there, can you see the bed? Can you see is the treatment table in the picture there?
Yes. Well, I think.
Okay. Do you want me to stop sharing my screen?
Yes. Yeah, everyone can see the screen. Yes. Yes.
Can you see it? Is that larger now?
Yeah. Perfect.
Okay, good.
Yeah.
All right, excellent. So, I'll move that back a bit. Yep, so, it's the right one. Yeah. Okay, so this is Mark, everybody. So I'm just going to ask him a couple of questions. So we'll just see you there for a minute. Okay, so the right knee is the knee that's really bad. And how long have you had the osteoarthritis in this knee?
Oh, 15 years.
Okay. Yep.
It was secondary to an ACL rupture with an ACL graft, a hamstring graft, 30 years ago, and I started to get some pain about 15 years ago, and it became quite bad around about 8 or 9 years ago.
Okay, yeah. So so at the moment, what are you limited with what you can do? Like how is it affecting you day to day?
I'm I got to a point where I was going to have a knee replacement done because the flexion of the knee had gotten to a point where it was affecting my lifestyle. I couldn't get in and out of cars easily. I couldn't sit down easily. I had to push off when I stood up. I had an inability to be comfortable driving a car because my knee was in a position that was uncomfortable. So the flexion was just gradually got worse, and there was pain associated with moving. I have to go down steps. Instead of walking naturally down a step, I have to stop on each step, and I can't step naturally down a step. So that sort of behaviour, it makes you feel old. I'm 60, nearly 64, and I walk in my mind, like an 85-year-old. And I don't want to feel like an 85-year-old. I want to feel my own age. So it's mental as well as physical.
Yeah, for sure. So we've had, so you've had 2 shockwave treatments already?
Well, what happened was I listened to Tina's last presentation, and she mentioned getting extra flexibility in patella tendons and in knee joints. And I'd just been told by a surgeon that if I had a knee replacement, I wouldn't get more flexion. I've also spent $5,000 in many attempts with many clinicians to get more flexibility in the knee and had no success. So I heard Tina mention this in the last presentation and asked her about Shockwave giving flexibility back to a knee joint. And she suggested a technique I try. I have a Shockwave machine at home because I've sold Shockwave equipment for 20 years. So I actually have a unit myself at home. And I've done 2 treatments on my knee. And I've gained at least 14 degrees in extra flexibility in 2 treatments. So I'm a little bit amazed, a little bit pleased, and really keen to see what Tina's treatment is going to achieve tonight in terms of I can't expect that she'll get more flexion out of it. If she does, I'll be amazed.
Yeah.
But I obviously want to see her technique.
Excellent. Okay. So I'm just going to pull the camera down a little bit. So can everyone see the knee there? You can see Mark's knee. Okay.
Perfect.
Perfect. Okay. So I'm actually going to draw on Mark's knee. So hopefully this makes it easier for you to see. I want to draw the shape of his kneecap. So if we mark, so at the moment, if I assess Mark's knee, I don't know if you can see that, but he doesn't have any move. His kneecap doesn't actually move in any direction. So if I ask you, can you lie down, Mark? And just to where you're comfortable, bend the knee by yourself. Let's see what you've got at the moment on your own. Yeah. Is there pain there or discomfort?
Discomfort here.
Yep.
And pain in the back where I got that cast damage from the original cast. Remember I told you?
Oh, yep. Yep.
So tightness in the
tightness
back
in there. Okay. Yep. So his kneecap doesn't move very well. So quite a lot of the time with osteoarthritic knees, we do have a kneecap that's very restricted.
And we know that for the knee to flex, the kneecap has to move down. So in order to get flexion, we need a kneecap that glides down away from the thigh towards the shin. So when we have a kneecap that's very stuck in all directions, he doesn't move that way or that way, it's got nothing. So it's very hard to expect this knee to flex with the patella that doesn't glide. So if I can create some lubricant around that patella, give him a little bit of glide, and then encourage him to have that little bit of extra movement. So we're going to shockwave through the joint line, laterally and medially, and we're going to go around the poles of the patella. So if I mark, this is his kneecap. I'm going to give you a nice patella tattoo. And I'm going to mark the 2 top poles of the patella and the 2 bottom. Good. And then I'm going to mark laterally the joint line and medially the joint line. So I've got 6 spots I want to actually target. So I'm going to deliver shockwave, and I'm going to use the power handle because we know that's the one for bony indications and we have a bony problem. And I'm going to share the shockwave around the whole area, trying to get as much energy into all the tissues. So inside, deep into the joint between the tibia and the femur. And therefore, when we're trying to get a bit more flexion, we don't have such a bony block at the end there. The other thing that is always interesting for me is what the tibia does. So when we have a knee like this that's very stiff, and he's been walking around avoiding bending it because it's been painful and he doesn't have the range. So all of a sudden, everything around it becomes very stiff. So the hip, the foot, the ankle, all those joints also suffer. So even though we have a knee problem, it's impacted the way he walks, and he doesn't like to bend this leg. So to give him that confidence back, it's really important we understand that when we bend the knee, we've got the femur moving forward on the tibia. So there's a bit of a shearing that happens at the knee joint. And the other thing that happens is the tibia needs to rotate internally. So for us, when I check his rotation in his tibia, there's not much at all. So he doesn't have that movement either. So I'm going to treat him with the shockwave, and then I'm going to show you how I support a knee to encourage more flexion, because that's the biggest problem. So as people get older, going up a step becomes very dangerous because they don't have flexion, so they often trip. And then they fracture a hip, and then all these other things happen. So knee flexion, not just for walking, but just so they're safe, is super important. Okay, so I'm going to turn this machine on. I'll come around here, so hopefully you can see. And we're going to apply the gel, so you can lie down. Do you want to move down a bit? Are you okay? So your head's on there? Are you sure? Okay. So make sure your patient's comfortable. So we're going to start. I'm actually going to start. So I know there's no movement there. I'm going to start on the joint line first. So this is the power handle for those who haven't seen it. And compared to the Evo, it has a longer barrel here. So it's obviously the bullet that travels further, so it can actually emit like a stronger shock wave. Okay, so that's probably the biggest difference in the two. They don't look that different, but if you compare them side by side, you can see that that one's got a longer, the red one's longer. I call this one the Ferrari because it goes faster. So we're going to apply this first. So you okay there? Okay, so I'm going to set the machine. We're going to start at 2 bars of pressure. We're going to deliver 2000 with this first lot, and I'm going to set the machine to 10 hertz. Okay, so we know that like below 8 hertz, we don't really get a therapeutic change. And we also know below 2 bars of pressure for this indication, we're not going to get much of a change. So we're going to see how Mark goes, and I'll just ask him for feedback as we go, and then we'll determine how much more energy we put into the tissue. Okay. So you ready? Okay, excellent. So I'm going to turn that on, and I'm coming from, normally I'd stand closer to the patient, but I want you to be able to see. So are you okay there? Yeah. So I'm compressing the head there, so just breathe in. Can you feel that traveling deep into the knee joint? Yeah. So remembering the power handle can travel to a depth of between 5 and 7 centimeters. So it's quite a lot, and it actually can, you know, help. If you think about it, if we go 5 to 7 centimeters medially and the same laterally, we're close to covering most of the joint. You okay there? Yep.
Well, not okay, but
You're doing very well. Good. So I'm just keeping an eye on the delivery of my waves, because I want to deliver, as I said, all around these 6 different positions. Are you getting any referred pain? No. Good. So I'm moving up and down the joint line to distribute as much of that shockwaves all along the lateral joint there. And then sometimes I can add a little bit of flexion, because that's what we're trying to open the joint a little bit more. So if the patient's okay, I play with the position of the joint. You okay there? And as I'm opening the joint, the shockwave can be deeper. You feel that different?
no.
Okay. Out of 10, how's that at the moment?
Oh, it's a 7.
A 7? Yep. Let's drop there. I'm going to drop you down. Great. So I'm coming to the inside. I'm going to do the same. So just keeping, he doesn't have full extension either, which is also quite common with an osteoarthritic knee. So I'm running just along the medial joint line. How's that?
It's less.
Less pain? So out of 10? A 6? So I'm going to put it up a little bit. How's that?
7.
7? Okay. So it depends on your patient and what they can tolerate. So really important that you keep asking them how they're feeling. Is that referring anywhere? Can you feel that traveling deep into the joint? Good. If I flex the knee slightly, do you feel like it goes deeper?
Yes.
Yep. So if you can open the joint a little bit and get that blood flow in a little bit further, that's going to be really helpful. So with Mark, the medial side of his knee has more wear than the outside of his knee. So I'm not surprised this side's a little bit more tender.
So how many, is that about 500 shocks you
Yep,
put in?
so I've done
side?
about 500 on each side. Because the inside's more tender, I'll probably give it some more. So let's go now. I'm going to start working around the patella. Now this is quite uncomfortable for the patient, but super effective. So I need to try and create some space under his kneecap so I can then get it to glide. Okay, you good? All right. So I'm putting you back down to 2 bars of pressure. Let's see how we go here. So if we want a patella to move inferiorly, the top poles can actually help lift it and then help push it down. Okay, so I'm actually gonna hold. If I can, try lift it a little bit. You okay? Breathing in and out there. Good. So I'm directing my shockwave to go underneath that border of the patella. I'm just moving around there. So think of doing, if this was a clock, think of you're going from 12 o'clock to 3 o'clock. Work around the top quarter of that patella. Okay?
It's no pain.
Good. So out of 10, that's all right?
3.
That's okay, excellent. And now?
Pain easily came from...
That's already eased off.
If you were on the actual bone.
Yep.
And once you get into the tendon itself,
It's fine.
Less painful.
Yep, great. So I'm going to go medial now. So it almost feels like scar tissue that's around a knee that's become very fibrous, very stiff. We're working around there. Okay?
Yep.
Good. I'm going to turn it up a little bit more.
Oh.
Doing very well, so we can turn it up a bit more. And then we're going to come at the bottom here. You okay? How's that?
That's the most painful.
That's the most painful?
Positive being a part of it.
Yeah.
But
So breathe, just try and relax as much as you can. Let me know when it starts to ease. So very common that the medial side has more compression, more wear, and more pain. Out of 10, how's that?
yeah, that was up there.
Yeah. So playing with the direction of your shockwave is also helpful. Breathe, breathe, breathe. Okay, so let me know when that starts to ease. It's easing. Good. And we're going to come round to the last one, the last pole here. Breathe, breathe, breathe. Good, you're doing really well. So we've got him almost at 3 bars of pressure here. He's doing super well. And we're done. Well done. You okay?
Yep.
You want tissue?
Want to cry.
So just wiping the gel away. Okay, so the first thing I'm interested in, I want to see, have we got a little bit more play in that patella? So can you lie down for me, Mum? Yeah. So I'm just going to see if I can wiggle it around a little bit. There's a little bit more movement there, which is good. So you can be pretty aggressive and try, just encourage. Can you feel that?
Oh, I can feel it.
Yeah.
Yeah, okay.
So the difference is they often describe, a lot of people will say things like, oh, you know, they can feel crepitus, they can feel like sand in the joint, it feels very dry. So the biggest thing they say afterwards is that they say, oh, wow, that feels really different. So now, can you bend your knee for me? Good. And straighten. Go again by yourself. Yeah, so how's the pressure around there?
Well, the pain there, there's no pain there, there's no tension there
Yep.
anymore.
Yep.
And the pain in the back is even,
A bit less?
well, there isn't any.
Oh, good. Excellent.
It's now tight up here because the leg is much.
Going further.
It's gone further than it's gone before.
Yeah, so it's quite common that they'll feel like there's been a shift where the tension is once you've got more range. So now if I do this to you, relax your leg for me, nice and loose. So I want to feel gapping. See if there's a little bit more play. See if there's a bit more rotation in the tibia. I'm really interested in that. And I'm going to show you how I'll support it now. So we talked about reinforcing the movement that we're trying to achieve with the shockwave and making sure we've got some support. So I'm using some active tape here. So just a strip that's probably 2 feet long. And I'm going to start roughly one hand above the knee. And because I want internal rotation, I'm going to come around the outside of the knee here, and then I'm going to wrap around the shin. So it encourages, when Mark stands up and walks, it encourages the tibia to rotate inside, because I know that's going to help maximize the flexibility we've just gained using the Shockwave. So then he leaves, and I've done the Shockwave. We've got more movement in the patella, which is great. We've got more flexion, which is excellent. And then we've got support to encourage that position to maximize the benefit. Really important that you try and do that so people actually get more out of the Shockwave once they leave. So we're going to start that tape here. We put a little bit of stretch on this tape so it helps unload the knee and take that pressure off. We're wrapping around laterally and we give it a nice rub to stick it down. And then I'm going to wrap here around the shin. Sorry about the hands, Mark. It'll be fun getting it off. And then we're going to spiral all the way around. And we don't stretch the ends of the tape, but we put a little bit of tension so you can see the words start to stretch out a little bit on this active tape. Okay, so Mark, now can you straighten your leg there? So we keep the knee flexed when we apply the tape. So can you bend your knee now by yourself, far as you can? Good. So can you feel the tape sort of helps encourage that a little bit? I'm going to get you to go for a little walk so you can test it out.
I'm interested to see with the goniometer whether the...
Tina, we have a couple of questions from participants. How many Shockwave sessions per week would be considered productive?
So we can, as long as you leave a gap in between, you can easily do 2. The recommendation is generally once the normal protocol for most of the conditions are once a week. If you can do that for 3 or 4 weeks, that would be great. So with the, how's that, Mark? Would you like to come back and just let us know how it feels? What you're noticing, or?
Well, bizarrely, before we did the session, I was looking in the mirror at my knee and I noticed that my leg was turned out. And now it's straighter. I'm standing straighter and walking. I seem to be planting my foot in a different way.
Yeah, so when you've got an osteoarthritic knee, the shape of the leg becomes quite deformed. So it becomes like a varus deformity quite often, where we've got a lot more stress on the one side of the joint. So all of a sudden the foot starts to change position. As I said to you before, the tibia changes position and makes it very hard. So we've got the tape helping him plant his foot correctly so the shin actually sits in a better position. We're unscrewing that knee a little bit, which will maximize the flexion. But it also, the important thing is that overall his gait will be better, so he's not limping. So less stress on the hip, on the foot. He's actually going to dorsiflex the ankle a little bit more. And all those things make a big change to how he feels just every day when he gets up. So the tape, I say to people usually, leave the tape on 4 or 5 days and just leave it on. It's waterproof, walk around, you can do all those sorts of things. So the active tape I've used here is like it's not a K tape and it's not a rock tape. We actually, it's like a bungee. So it actually stretches back and it actually supports and stretches in all directions. So it actually gives us a great recoil, as I said, to maximize what we've done in the knee with the Shockwave. We're unloading the joint.
Okay, so so we have a question which came at the beginning and which is linked to what you're saying. If you add an extra treatment such as taping, how do you know that Shockwave will be the result? Will be the cause of the result?
The tape is purely to support what I've done with the Shockwave.
Okay.
Does that make sense? So yeah. I will always tape every tendon I Shockwave. I will always support it. Doesn't matter if it's an elbow, if it's a shoulder, I always support it because I want to maximize the benefit of the Shockwave.
Okay.
And I want to make sure that person has support all the way. So regardless of what they're doing, if they're playing sport or if they're going to work, or it doesn't matter, that I think you need to try and keep the joint in the position that you want it, or the tendon in the position that you want it, to give it the best chance to heal. But just taking the pressure off.
Okay, perfect. Thank you. We have another question from Max. asking what would you prefer to use the Power Plus handpiece instead of the blue handpiece? Is it because it's more efficient or?
Yep. For an osteoarthritic knee, when the studies that were done for osteoarthritis use the power handle once a week, 4 weeks. So, and because we understand that the way it delivers the shockwave, because it's higher and it's the energy density is much higher, quicker, and then it tapers off. We know that that's better for a bony indication. So if we have a calcified supraspinatus tendon, we know it's better. Or if we have a stress fracture, we know the power handle's better. It's more painful because we're talking about a bone. But because it's only a short duration, and someone like Mark, I know if I saw him in we did 4 sessions, we'd get more range back. He won't have his knee replacement. Like, I'm that confident that if we gained that much range in 1 session, if we do that weekly, we can make sure if he doesn't have the pain and he's got function, he can do all the things he wants to do. And he can delay having a knee replacement. And it's really important because joint replacements still only last 10 years. So if we can give people a few more years of good function and no pain, I think that's really life-changing for them.
Definitely. We have another question from Bruce asking if you are using KT tape or rock tape.
Yeah, so rock tape is also a K tape. It's not K tape. This is an active tape. It's also known as dynamic tape in some places. So it's a different product. So K tape won't unload a joint or a tendon. It's great for lifting the skin and providing blood flow. So good when we have inflammation and things like that. So it's not great to unload a tendon or a joint. The active tape is better, or the dynamic tape.
Okay, perfect. Thank you. Another question, lots of questions coming. Would you use dry needling in the same session when doing shockwave treatment?
I personally wouldn't, because then I sort of don't know. It's sort of, because dry needling, obviously we can get quite deep as well, but I feel like I could use one or the other. I don't need to use both. But for an osteoarthritic knee, dry needling won't give me the same change. It will help me release trigger points around the knee, but I do not get the same change that I nowhere near as good an effect as I do with the shockwave.
Okay, thank you. Another question from Rebecca. What would you do? Would you do it differently for a meniscal injury?
Meniscal injury, if it's very acute, I find they don't respond as well. If someone's got a chronic degenerative meniscus and cartilage, that isn't fantastic. So if it's an old injury, I think they work well, and I would treat the joint line more closer to the meniscus. If they've got patella movement, you don't need to treat it. But if that patella doesn't move and you're trying to give this person flexion, you have to get the patella gliding. It's crucial.
Okay.
And then get the tibia moving. So if you get patella and tibia rotating, you'll get flexion.
Okay. Perfect. Thank you. Another question from Bruce. Would you treat popliteus separately?
Popliteus?
Yes.
Yep, you can treat that separately. Yep, I often do that, release that with my hands, as I would then treat through the hip. And then I often treat the foot and the ankle with every knee I see. So as an osteopath, we don't just look at one joint. Obviously, for the sake of this exercise, I'm treating just the knee. But if Mark came in, I would do a treatment that would include probably all the way up to his shoulder. Because he limped in, I already know he's making compensation all the way up his body. So I need to make sure we address all those things, not just the knee. Because it's an old problem. He's had it for a long time.
Yeah. Okay. Thank you. Another question from Judith. If the patient feels pain after the treatment, how long does he have to wait for the pain to reduce? Or is there any additional treatment for the pain?
Yeah, so quite often, like most people, there will be a reduction in pain in the session. Yep. So when they get up and you retest them, you might say, do a squat or go for a walk or show me, what you're feeling. So when you've done that, that's when normally the pain is actually less while they're still with you. But if for some reason you feel like they might get a bruise, or you think they might be worried, you can just tell them they can go home. They can put some ice or heat or whatever you think is appropriate.
Okay.
But I generally don't tell them to do anything apart from the exercises I've prescribed.
Okay. Thank you. Thank you. We have another question. Another question from Louise, who's talking about a case for a specific case for a patient. She has a patient that already had a knee replacement. Despite rehabilitation, she battles to gain flexion and extension and maintain it. It is greatly improved after soft tissue treatment, SCAR, ISTM, and PNF, but reduced again the next day. She's had a manipulation under anesthetics after the replacement. The surgeon says the restriction is due to scar tissue. On palpation, she also has limited patellar movement. Is there any way she can shockwave that knee?
So again, it really depends. Like, it's probably good to speak to the surgeon, but if she's got a lot of scar tissue, even if you start on a lower setting with an Evo handle, and break up the scar tissue around the knee, get the patella gliding, that will make a big difference. Get the tibia moving, that will also help quite a lot. So you can definitely work around the area and try break it up, no problem. Because scar tissue is a massive issue for so many people.
Okay, thank you, thank you. This is a specific case. Thank you for this. I come back to the treatment with osteoarthritis. A question from Elan. When moving along the joint line, how much contact time must you have before moving to another point along the line?
I just keep it moving the whole time. So there's been a few questions about that, because when I first learned to use Shockwave, I was told to keep it still. But then I was told that, you can change direction of the Shockwave and you can move along. So I just keep it moving continuously. So spread the gel along the joint line and just keep it moving. Yeah. So try and visualize that the Shockwave gets sprayed out. So even though we're using a 15 millimeter tip, you're covering a bigger area than that. It's probably double that when we spray it. So if you're moving it, you're going to cover most of that medial side of the whole joint.
Okay, perfect. Thank you. A question from Gislaine in Brazil. Do you use shockwave therapy on acute lesions or only in chronic ones? This is a question actually that comes regularly in our webinars.
Again, it really depends, because if you have a lot of swelling, I find sometimes very acute swollen joints don't respond well to shockwave, because we're increasing more blood flow, we're creating more cavitation. It's very hard to compress tissue that's full of swelling and to be effective, because we've got all this extra. So if you can get rid of the inflammation, then use your shockwave. But when it's very swollen, I don't think it works very well.
Okay, thank you. Thank you. Lots of questions. Again, a question from Jack. For tendinopathies and joint osteoarthritis, have you found that you need a minimum of 2 bar of pressure to create a beneficial change? Is anything less not beneficial?
So the studies tell us again that less than 2 bars of pressure, we don't get a significant change. It's not enough air going and creating enough cavitation. So that energy density we talked about on the graph, so feeling like you've got, more energy going into the tissue, even with a tendinopathy, we know that 2 bars of pressure is the minimum.
Okay, perfect. Yeah, true. 2 bar is the minimum, definitely. A question we had concerning the penetration of depth of the power end piece. How deep can the red handle penetrate into the tissue?
So we know between 5 and 7 centimeters.
Okay, perfect. Thank you.
So it's more than the Evo. The Evo is between 2 and 4 generally.
Okay. We have a question from Greg Robinson. who heard that focused shockwave is more effective than radial for osteoarthritis, also due to less pain produced during treatment. Any comment on a radial over focused shockwave treatment?
Yeah, so I don't have any experience with focused shockwave, sorry, so I'm probably not the right person to answer that. Yeah, I don't really know because, as I said, I've only used the radial shockwave for the musculoskeletal indications that we see. So we don't have a focused shockwave, so I haven't actually had an opportunity to use one.
Okay, thank you.
Sorry. That's okay.
No problem. I'm just reading. How long? We have a question from Waikiki. How long should we perform shockwave treatment roughly on each point? Coming back to the treatment you did on Mark.
Yeah. So anywhere between 500. So if you've got someone with, you see their X-ray and the inside of the joint is very, very worn and very deformed. So you think that's way worse than the outside of the joint. So you might deliver 1,000 to the medial joint line and you might deliver 500 to the lateral joint line. So quite often it depends how they present, where you think needs more energy into the tissue. So what area needs more lubricant? What area needs more substance P to be removed? What's causing most of the pain? So those questions will really dictate where you spread your shock waves. But around the patella, I generally go 500 at each pole. So 2 at the top, 2 at the bottom. And so therefore I've covered the whole kneecap, and the undersurface of the patella then will allow me to actually glide. So that probably makes the biggest change to any knee.
Okay, thank you for these additional details. Another question I'm reading at the same time. During the treatment you did on Mark's knee, why didn't you also treat the ITB due to his fascial connection and the hamstrings and gastrocs and also his gluteus?
Yes. Yes, so I would treat all those, as I said, I would treat everything from his foot all the way up to his pelvis and everything in between. So I can definitely change the 15 millimeter applicator. So I'll show you. On the soft tissues like ITB, I will often use the larger head. So I will go the 36 millimeter and use that like an iron and treat the rest of the longer muscle belly. So along ITB or hamstring or through sartorius, through the calf, because he's definitely going to have issues all through there. So definitely, but I usually swap to the bigger head if I'm covering a large area.
Perfect, thank you. We have other questions. If you treat that, I think you already answered this question. If you treat with other techniques, let's say if we combine shockwave therapy with other techniques, how do you know if shockwave was the technique that worked the most?
Okay. Yeah, so I would measure his range. I'd use the shockwave, recheck, so I know what shockwave's done by itself. Then I do the other treatment. So I've treated, even though I have used it on an ankle that was very arthritic, on toes that are arthritic, on thumbs that are very arthritic, I get the same change in all those joints, so they all glide better afterwards. So I always check before and after, what's their range like, what's their pain like, what's their strength like. All those things will give you that information. And then
I'm losing you, Tina.
Have the feeling, and then I do the other treatment.
I'm losing you, Tina.
Really?
I'm losing you a little bit. Yes. Probably because we're getting to the end of the webinar. I don't know. Could you please just repeat what you said about the efficiency of shockwave combined with other techniques?
Yeah. I was just saying, basically using the shockwave first, and assessing the benefit of the shockwave before you do any other form of treatment. So then you know what what you've gained from the shockwave, and the patient knows too. So it's very clear. You say, like, hey, we've got no movement here. They can feel that. They know where their limitations are. So you can do the shockwave, get them up if you need them to, walk around, retest, and then get them back on the table and do the rest of your treatment, and then compare. So then they understand what they're getting from the rest of your treatment versus what the shockwaves bought for that joint.
Okay, perfect. Thank you very much. Another question from Deborah. Have you ever treated lymphedema in the arm after breast cancer? If yes, how would you treat it?
Yeah, I haven't personally, but I have spoken to some practitioners who have, and they find they use the broader head, the 36 millimeter head, and they follow almost like the fascial plane along the upper limb. So that's the path they sort of use to try and push the fluid up and just encourage cavitation in lots of areas to help create that flow of the lymph.
Okay, and do you know how many sessions would you do per week for this kind of indication?
I think it's still once a week, the protocol that's recommended.
Okay, thank you. We're coming to the end of the webinar. Another question from Marinda, which is always asked during also webinars. Are metal plates and screws contraindicated in the area? Especially in the knee, in the patella, we may have some metal plates. So.
Yes, that's correct. Yeah, so basically the shockwave can sort of bounce off like a metal surface. So again, just appreciate the depth of where these things are. So sometimes if, they're very superficial, obviously they're going to be quite painful. But sometimes if people have had issues with the plateau and the screws are quite deep, like if you've had an ACL screwed and you've got a big knee, my shockwave's not going to reach the ACL where the screw is. So you need to always appreciate where you're directing your shockwave and the anatomy in the area. So if you've got someone who's had surgery, it's always best to have films, so an X-ray or an MRI that shows you where these things are, so you can avoid them, but you still can apply shockwave around them. So I've done, like, people who have very deep, thick scar tissue post-surgery, I have used shockwave, even though they have screws. I'm just mindful to avoid them because I've got the film as a reference, so I know where those screws and plates are.
Okay. And how long do you...
Sorry, it's very beneficial for the scar tissue after surgery.
Ah, okay. So how long would you wait after surgery, after the patient got a metal plate in his knee, for example? How long would you wait to perform a shockwave treatment?
So again, I'd make sure all the scars were basically healed. No different to you. If you were going to do deep friction with your hand and break up scar tissue, you could use the shockwave on a low setting and gradually work around the area. So you could do that, 6 to 8 weeks. Once the surgeon says they're good to go, really.
Okay, perfect. Thank you. We have, I don't know if you have a bit more time because we have other questions. A question from Marsha: what exercises do you prescribe for patients being treated with RSWT for osteoarthritis of the knee?
It really varies, again, it's very hard to give, we don't have a general one exercise or a few exercises for every person. It's really case by case. But with someone like Mark, who's got a chronic knee, who's been limping for a long time, protecting the knee, the exercises would very much address every part of his body. So it would be looking at restoring normal gait. So I'd be looking big picture, making sure his foot, his ankle, his knee, his hip, his back, all work well together, and he starts to take pressure off those areas.
Okay, perfect.
So
thank
the
you.
exercise isn't just for the knee.
Okay, thank you. Another question: has shockwave been used much with Dupuytren's contracture fibromatosis in hands or feet?
Yes, I've actually used it I've used it on 3 patients with a Dupuytren's contracture. Very effective. So I've used, because of the depth of the tissue, I've used the broader head, and a lot of these people can't open their hand fully. So they can open it enough for you to fit the head. So if this is the head of the Shockwave, even if their hand doesn't fully open, you can place the head in there and you can conduct the Shockwave, into their palm. So you can work around that. So I use that sometimes to loosen up the area, and then I'll use the 15 millimeter and target those little protein deposits that are really controlling the tendon. So I break them up individually. So same as we're talking about the plantar fascia in the foot, not that different to the hand. I treat them very similarly.
Okay, so you start with a low pressure because
I want to soften. I want to create a bit of blood flow and soften things, and then I tend to go in and target where those protein deposits are that pull the palmar fascia and really contract the hand.
Okay, perfect.
Yeah.
Thank you very much.
They get excellent results. They're really happy.
Okay, so you do 2,000, 2,500 shots on the head.
So quite often I deliver 500 with this head, the bigger head. 500, get the blood flow into the hand, start to open up the fingers, and then really target those really annoying bits that are really responsible for that contracture.
Okay, thank you.
Yeah, so generally it'll be 2,000 to the hand.
Okay, perfect. Thank you.
We will, well, maybe we have additional questions, and probably we will end with this last questions. Question from Igor, how applicator? No, a question from, a question from Andrew. Can you describe a protocol for treating greater trochanteric pain syndrome?
Yes. So again, with the greater trochanter, we tend to it depends on the person as well. So if I have a really large person, I would often use the power handle because I want to get to the tendons that attach to the greater trochanter. So if I need to get through big, strong buttock muscles, I'll use a power handle. If not, I lie the patient on their side and I'll work along the border of the greater trochanter where all the tendons attach. And so again, I will deliver at least 2,000 shocks all along those tendons, but I will move it right along the posterior border.
Perfect. Do we have time? It's the.
I think we just got one more slide. Do you want me to share that?
Last question: Is it safe? Is it safe to use shockwave treatment on a TKR?
On what? Sorry.
On a TKR. This is.
Oh, total knee reconstruction. Yeah,
probably. Yeah.
Yeah. So again, if we've got a metal knee, or depending on what the material is, so it might not be very comfortable. So if you're treating the soft tissues and you can use the Evo handle on the soft tissues around the joint to try and help with mobility there. So you can use shockwave, but just be mindful of where your shockwaves are going and the anatomy of the knee.
Okay, perfect. Thank you. Thank you. And we have other questions, but maybe we will answer them by separate email because it's already over time. So okay. I leave it up to you. Yeah, I leave it up to you for the last slide.
Okay? Yeah.
Yes.
Okay, so thank you everyone for joining us this evening or this morning. Please stay in touch with the SDSA Academy. You can register if you like for any of the next webinars that are coming up, and the details are there. If you want to get in contact with me, you can find us on Instagram, Facebook, or via our website. And we are going to be posting some of the Shockwave videos to our YouTube channel, so you can subscribe to that if you like. If you want to contact anyone about getting a Shockwave machine, the details are also on this slide. And I'm going to be doing a taping to unload tendons and joints webinar in July, and a neuromobilization. So feel free to follow us on social media. We'll be announcing those on there. As I said, I think it's a great adjunct to the shockwave treatment. And, I think if you get comfortable and confident, you sort of become known for delivering shockwave, that if you know, people will travel from all over the place to see you, and you know, because you're offering this treatment that's, you know, going to save them having surgery. So I'm sorry we didn't get through more of the other practical examples because we had lots of questions, but if you have any questions, feel free, you can contact MC or myself, or and hopefully we'll see you again soon at some point.
Yes, yes, definitely. Thank you, everyone. Thank you, Tina. It was always, well, it's always a pleasure to have you online. Thank you also, Mark, for loaning your knee for this practical session. And we'll see you online next time. We'll keep you updated. Please consult regularly the planning of our courses online, and of course, stay tuned. And if you have any questions, of course, please contact Tina, and we'll keep you updated anyway by email, by sharing the slides, and also the link to the recording. Thank you, everyone, again, and stay safe wherever you are, and take care, and see you next time online.
Thank you.
Thank you, Tina. Bye-bye. Bye-bye.
No worries.